Hello, good afternoon and good morning to everyone on the line, and welcome to the third webinar in BioVigil's webinar series, A Nurse's Perspective on Hand Hygiene. I'm your host, Amanda Holden-Sinisi. A few housekeeping items before we get started today. Your line is already muted, so you don't have to worry about muting yourself. This webinar is definitely for you, so please do ask questions using the QA message box. We will address all questions at the end of the presentation. For those of you who are with us for the first time, welcome, and welcome back to those of you who have been with us before. We're very happy to have you. BioVigil's webinar series features key opinion leaders who are making a significant impact with patient safety and experience in hospitals. Speakers will share data insights and best practices that have made their organizations best in class in the culture of staff and patient safety and driving exceptional patient experiences. I'm very honored to introduce today's speaker and registered nurse, Nifiah Reid. Nifiah is a dedicated community and patient safety activist. She is also the Director of Implementation at BioVigil and serves as an advisory board member, trainer, and coach for many organizations throughout the Detroit metro area. Now I'd like to welcome Nifiah Reid to give you her perspective on hand hygiene.
Thank you everyone for taking the time out today to be a part of this webinar. The intent of today's webinar is to begin a dialogue that will assist us as healthcare workers to ensure that we are providing for patient safety and working toward the best patient outcomes possible. For those I have not had the pleasure of meeting in person, as Amanda stated, I am Nifiah Reid, Director of Implementation here at BioVigil Hygiene Solutions. In partnership with many of our current clients and some of you on this webinar, I serve as the clinical subject matter expert for our team to assist in developing a customizable electronic hand hygiene solution for hospitals and clinics all over the United States. I bring a passion for nursing, a sense of commitment, dedication, and professionalism to every aspect of my work, and I have a heart to serve. This job gives me the opportunity to serve patients all over the world, right alongside many of you. My professional experiences are diverse and include working as the Director of Nursing in an assisted living community, a school nurse, a hospice nurse, and prior to my appointment at BioVigil, I was the clinical nurse leader for the largest third-party administrator in the U.S. and a longtime critical care nurse at a hospital here in Ann Arbor. I've been blessed to experience several disciplines of nursing, and these experiences have humbled me and made me a better nurse and a better person. I am extremely passionate about patient safety and hand hygiene, and it is one of the reasons I was drawn to join the BioVigil team. I believe in the system and its success for our clients when consistent practices and processes are married with the system and enforced. When I am in a setting where I have to introduce myself and tell people what I do for a living, and I tell them I travel all over the U.S. and teach doctors and nurses and other care providers about hand hygiene, they're usually a little taken aback. And I usually get, really? You have to teach care providers that? Shouldn't they already know that? And my response is always, we do, and sometimes we forget, so I have a great job because of it. My foundation as a nurse was built in intensive care for greater than 8 years, and it goes without saying that there are some vicious organisms, both acute and chronic, that reside with the critically ill population, some that I believe we are yet to identify. One of my greatest frustrations while practicing was that there was no consistency with hygiene or infection prevention protocols among any discipline on the units. Not to say that those protocols were not in place, but they were not consistently followed. And anybody who says that they were, that's a complete untruth. We as care providers didn't always do a great job of holding each other accountable either. In healthcare, there's a hierarchy of positions by nature and training. However, when it comes to patient safety and decreasing hospital-acquired infections, everyone should be considered equal, and it must follow the same rules. Everyone needs to feel empowered to ensure that the right things are happening. A doctor should not be able to get out of the protocols simply because they are a doctor. I myself have become very bold now. I don't care who you are or where we are. If there's an instance in which you should have washed your hands, I'm telling you to. On last year in September, I was blessed with my first grandchild. A physician entered the room to examine my daughter's cervix to check what station she was at. That physician introduced herself and proceeded to put on her gloves. I immediately stopped her and said, "Are you going to wash your hands?" And she said to me, "What?" And I said, "Are you going to wash your hands?" She says, "I have on gloves." I had to tell this physician very boldly, that does not negate the fact that you need to perform hand hygiene before putting on gloves. To which she turned around, took off her gloves, and washed her hands. It goes without saying that every other staff member that came into that room to see my daughter clearly washed their hands before touching her or anything in her environment. That being said, me saying something caused a positive reaction. Saying something and doing something makes change. I have now been away from the bedside for full-time for over 5 years, and I still hear the same reasons why we choose not to do the right things. I don't have time to wash my hands. I'm wearing gloves, or I was putting on gloves. I didn't see that sign. The sanitizer is not in the right place. If it was over here, I'd use it. And my favorite one, I don't like or I can't use the soap or sanitizer the hospital has. It ruins my hands. That last excuse really makes me wonder, if you can't use soap or sanitizer, what exactly are you doing? And that statement really makes it crystal clear of what's not being done. I think it's safe for me to say that no one comes to work with plans of spreading infection and disease, but because of the dynamic environment of the clinical settings, it just happens. And if we don't stop it, it'll continue to happen. When I worked in direct patient care and a staff member was in a rush or even trying to assist another colleague with patient care, on many occasions, hand hygiene protocols went out the window. And let's not talk about when we had emergencies. Unfortunately, I have to admit that I've been guilty of this as well. On other occasions, I've seen clinicians enter a patient's room, lift up the sheet, examine a surgical site, a chest tube site, waste bags, or whatever it was they were assessing at the time. They may or may not have had on gloves. They leave that patient's room and enter the next patient's room without performing any type of hand hygiene, and the process starts all over again. I've had to stop colleagues from entering or exiting a clearly signed contact precautions room and direct them to put on or take off personal protection equipment. I'm sure many of you can relate to this and have had to do the same thing. This is the hard part though, and it's a difficult task because you never know how your colleague is going to react. I would also like to say that this is just not a problem in one unit. I had the great opportunity of working in all the ICUs at my former employer, with the exception of pediatrics. But in pediatrics, the parents, just as I did, they correct the wrong behavior. And I've worked in several other environments. Lack of compliance is happening everywhere and in every clinical setting. I've worked directly with other peers who wouldn't even use gloves during patient care. They would tell me, "Oh, I'm old school." And when I started off, we didn't have gloves. Times have changed, and we have everything that we need to make a difference. And we have more knowledge than we've ever had before about the spread of infection. So let's use it. My question that I ask is why, when we know the right thing to do, we still don't do it? And the answer to that question, I answered it myself, is that bedside nurses don't usually have the full knowledge of the operation side of business. Our focus is patient-centered, and it tends to be singular. In the absence of this exposure, we don't understand the true value of the decisions that we make when we practice. So exposure to that information is needed. So let's get into this. The slide that you're seeing, if you would have showed me this slide as a novice nurse over 14 years ago, it would have helped me to realize the impact on how I practice and why the way I practice was important. New nurses and all nurses want to do a great job. No one wants to contribute to thousands of deaths and billions of losses in financial revenue. As nurses, we may not be highly exposed to financial operations, but what we do understand is money. And if the hospital is losing money, that's money that I can't get. I can't get a raise. I can't get tuition assistance. We can't get the new equipment that we need to take care of our patients. As you look at this slide, these numbers are horrific. Millions of patients get hospital-related infections. Billions of dollars out the door in direct and indirect medical costs. Hospitals are losing reimbursement, and as we know, Medicare is penalizing for these hospital-acquired infections. And we're getting increase in multi-drug resistant organisms. So what happens for those who know what the MDROs are, the cycle continues. We're continuously treating infections. We're continuously losing money. The top 3 things that we want to achieve as care providers is patient safety. We want to do that by decreasing our infections. We want to increase patient satisfaction, and we do that by decreasing the length of stay and readmissions. And increasing patient confidence. Full confidence from patients that you are doing all that you can to keep them safe. One of our clients shared a great testimonial of what a patient believed what was important and what a care provider thought was important. The patient came into the hospital complaining of chest pain and shortness of breath. As a nurse, our first thought is to grab the EKG machine, run the EKG, and see what's happening with the patient. So that care provider did exactly that. She prepared to do an EKG on this patient. This patient evidently was aware of BioVigil and what the system looks like. So that care provider's badge had turned red because evidently she grabbed the machine, rushed into the room to assess the patient. The patient put his hands up and said, "Stop, your hands are red." To that, she's like, "What? What do you mean?" He said, "Your hands are red." He pointed to her badge and she said, "Sir, you're complaining of chest pain and having shortness of breath. I don't have time for this right now." He said, "I don't want you to touch me until you wash your hands and that hand is green." That's a true demonstration of what's important to our patients and what's important to us. Now, that patient safety was important to that care provider, but in the patient's eyes, he knew that he was at risk. What we know that hand hygiene is the single most effective way to prevent the spread of infection. But in order to gain the compliance that we desire and so desperately need, we have to stop doing the same things over and over again, or we continue in a vicious, nasty cycle, and nearly 200 years later, we're still in the same space and having the same conversation. By the way, 200 years later, we're still in the same space and having the same conversation. We've been dealing with the same issues since the late 1800s. Florence Nightingale implemented hand washing and other hygiene practices in the hospital she worked at. While the target of these practices was to fight miasmas or bad smells, her hygiene practices achieved a reduction in infections. And as care providers and those of us who are licensed nurses, this knowledge is in almost every book that we have ever read. Next, what we know is that manual observations are not always accurate and not the most effective. They can't be the only way. They work fine for a time, but they're not effective anymore. And let me give you some examples of why. If my peer and friend is the monitor for hand hygiene compliance, how likely is that data to be accurate? It's not. And even if it's not my friend during the observation, the monitor is generally distracted and only has minimal time for the observations and can only see so much. So there are missing pieces, and we need to have accountability around the clock. Of course, when I know that somebody is watching me, I'm going to do the right thing. However, when no one is looking, I'm going to revert right back to my normal practice, which is probably not compliant. And in several other cases during manual observation, if a staff member was completing a non-compliant act that could result in the spread of an infection, that observer might say through gritted teeth and a small whisper, "Wash your hands before putting on gloves." And we all know the code words and phrases when something is being done wrong. Don't go to McDonald's and get the strawberry shake. That's an inside thing there. Although this is correcting the behavior in the moment, what's happening when there is no one there to correct us? And finally, Protocols are generally ignored due to the cultural rules in the environment. So let's talk about that a little bit. I referred to some of my pet peeves in my earlier story. Behavior is learned, and if bad behavior is not addressed, it's continued as acceptable behavior. The points mentioned earlier are true stories of non-compliant behavior. They're happening right now as we are on this webinar, and are examples of taught, long-standing, negative cultural behaviors that must be changed immediately in order to decrease risk to patients, staff, as well as financial risk to hospitals. Cultural change and behavior modification is a must. Looking at some of the cultural considerations, let's define that. A culture is a set of shared beliefs, attitudes, knowledge, practices, artifacts, and behaviors. The culture of a group is shaped by 4 elements. The intellectual purpose, and that is everybody's in the hospital is a professional trained care provider. Emotional attractor, the reason for being together, and that's the desire to serve others and help people get better. The knowledge that's acquired and the practices that are developed together. Any of these can be good, bad, or indifferent. We don't want either attitude. What we want is solid practices built on proven research and good outcomes. And finally, the intention that unifies the group. And that is working tirelessly in one of the toughest fields, hoping to achieve the best patient outcomes. Unfortunately, working tirelessly is not enough. It needs to be more to it. The goal then is to help the group assess its collective culture, be aware of, and forge a positive, accountable, and supportive culture. And in order to achieve behavioral change, you will need behavior modification. You're going to establish a shared purpose and build collective energy around it. Establish the norms, and that's the processes and protocols that need to be in place. And for those who don't want to follow them, you allow those people to lead the group. Use of a shared goal. You're going to challenge the culture that may be divisive or constraining. You want to take action here and be prepared for corrective activities. These are your hard conversations. For instance, Nifiah, we've monitored you on several occasions. You continue to be non-compliant with your hand hygiene or your patient safety practices, whatever the case is. How can I help you? These are the conversations that you got to have, although they are difficult conversations. And you want to recognize any positive behavior and any other successes regularly. It's unfortunate that many care providers' actions are not appropriate simply because they don't believe that anyone cares or appreciates what they're doing. And although we don't do what we do for thanks, it's good to hear every now and then, and it works great to reinforce positive behavior. If someone is recognizing the good that I do and is commending me for it regularly, you best believe that I'm going to keep doing it. As leaders, awareness of shared culture builds trust, cohesion, and a sense of safety. As leaders, you must ensure that the culture in your facility is positive, inviting, and supportive, engaged, and accountable. New nurses watch what seasoned nurses do, and they model that behavior whether it's right or wrong. An example of this is a staff member doesn't know that it's important to perform hand hygiene events before and after all patient interactions, but they know which computer on the unit allows you to get on Facebook and where you can go to secretly talk on your cell phone. We want all the right things to be taught as new orientees enter the organization so that they teach the next new employees correctly and that positive reinforcement cycle continues. We don't want staff members to get in the habit of thinking that it's okay not to wear PPE when you're going into an enteric precautions room, or think that you can just hold the mask up to your face and not wear it properly when dealing with respiratory isolation, or not wearing sterile gloves for sterile procedures, and the simplest action of not washing your hands before and after and during patient care where appropriate. I'm not talking about me or you or your staff. I'm just mentioning some of the things that I've heard at the nurses station around the U.S. So getting started to make change. How do we get there, and what exactly does this look like? First and foremost, you want to identify that there is an issue, that there's an opportunity for success in the area of hospital-acquired infections. Your facility may have a decrease in its hospital-acquired infections. However, if there is at least one contracted HAI, there's still an opportunity. Our job is to recognize that opportunity and to take the appropriate actions. You then want to acknowledge that hand hygiene may be a problem in your organization. So reviewing your current practices, protocols, and tools for appropriateness, and then reevaluating them to ensure that they serve the entire organization. And lastly, you want to start planning. You want to involve everyone. But herein lies the problem. You do this great project, you focus on this one aspect of care for weeks or months, and then all of a sudden you're working on something else. That is a very strong message to the staff that it was the flavor of the week, and now we're on to something new. You want to ensure that there's commitment to improvement and success. If I could identify employees of clients, I could list out 30 people who have recently told me, oh, I'll do this for now because it's just the flavor of the week, and next week we'll be on to something else. Real commitment takes time, dedication, enforcement, and belief in the process. To get that commitment, it's imperative to work with staff to implement solutions so that they feel like they've been a part of the process and the solution. This will surely get their buy-in. Nurses love to say that we didn't know about this or that, this change or that initiative, because it makes for one less thing for us to do until someone calls us out on it. If nurses feel that they have contributed to something good, everyone will know about it. So include them and get the word out. That's almost free advertising right there. Since I've been with BioVigil, I've been highly exposed to the business side of decision-making in hospitals. I've learned so much that I didn't know, and I continue to learn new and important things every day. Some of the lessons that I've learned through successful partnerships are each hospital has its own designs, rules, and goals. Every organizational culture is unique. There's no one-size-fits-all solution to any problem. And no communication and no collaboration equals resistance. During an implementation at a client site, I experienced a very distraught emergency room employee who was against implementing BioVigil in the emergency room. She swore, she yelled, and expressed very boisterously how stupid and demeaning it was for me to tell her she needed to be reminded to perform hand hygiene. She was in my face. She was very angry that I was even approaching this subject matter with her. Ending her rant with throwing the badge. Of course, I didn't argue with her and attempted to avoid her at all costs. The next day in the ER during the training, she sought me out. As I said, I was trying to avoid her. As she was walking toward me, I was shaking my head and thinking, oh my God, what's going to happen today? She pulled me to the side and apologized with tears in her eyes about her behavior on the day prior. She shared with me that her father died from a hospital-acquired infection. And if they had had a product like BioVigil at the hospital that he was at, he may be here today. This was very emotional for the both of us, and it became very personal. And as you would expect, she is very compliant with protocols due to her personal experience. She is a champion for change and patient safety. What I understood after this interaction was that her outrage was not a personal attack on me. It was against the system. It was the lack of communication and the lack of information that she was given in regards to the implementation of change in her hospital. Communication is key in getting anything done. When going through your implementation process, positive change starts from the top. When implementing anything new, it's important to communicate the why and provide evidence of the need before the change is implemented. It is also critical to eliminate any factors that may cause fear. Change is scary, especially for those who already have a 5 or 10-year or 25-year routine. As stated before, change is more successful when there's partnering and dialogue. Pre-planning, preparing, and communication is key. And I am going to say that over and over again. You want to communicate openly about opportunities, plans, and goals. Punishment and loss of employment cannot be the focus. It must be taken out of the initial equation. People are afraid that they're going to lose their jobs if they do something wrong. They're afraid that they're going to lose their credibility and have their character attacked. Reinforce the fact that everyone is a professional and can make their own choices. Many nurses have expressed to me that they feel demeaned when a new policy or procedure is imposed on them and they were not aware of it. It's difficult to find common ground when you don't know or understand the goals of each team, and in some cases, though, they don't seem to correlate. As I started out with this slide, your positive change is going to come from the top. Leaders who can instill trust, build confidence, communicate effectively, and role model the desired behaviors will bring about long-term cultural change. Peter Rockford, who is one of the thought leaders in industrial relations, wrote in an article on cultural behavior change that one of the most effective ways to change a workplace culture is to simply change the way you communicate. Communication is an essential human need. Positive two-way communication is the way we build strong, positive relationships. Yet for some reason, we seem to forget that in business. More often than not, most businesses rely on one-way communication. That is infrequent at best. By consulting with your employees and asking for their feedback and responding to their input, you start to create an environment where everyone feels empowered to do their job to the best of their ability. When you partner with the staff and communicate the plan, it also alleviates a lot of the concern of Big Brother. Developing policy and procedures that are consistent with patient safety protocols and that consider the staff workflow work very well also. Policy and procedures provide an organization with an important framework that ensure consistency in decision making. Without them, employees may not understand what is expected of them, and in the absence of them, managers make decisions that could be considered discriminatory or unfair. How do we get to our goal? What do we need to do? You want to position your organization to achieve success in patient safety. And you do that by removing barriers, whether they are real or perceived. On this list, as a nurse, these are all real barriers. Increased patient loads. I've never had to suffer this, but I've observed this on numerous occasions. When a nurse has 5 to 8 patients, it becomes a real challenge to provide good patient care, let alone follow protocols. Inhibited patient care. 10 different pieces of accountability equipment, and what I'm talking about is the phone, the Vocera, the BioVigil badge, and other patient care equipment, charting, verifying, ordering, and none of those things are integrated. It does take time away from patient care. We have to work on better integration for better patient safety. And proper resources. Bedside nurses don't get to make many decisions when it comes to hospital operations, policies, or rules. However, many of you on this line do. Be the advocate for those frontline caregivers to ensure that they have the right resources, and those who make the decision understand the workflow of the staff. Many of us have been there. However, You can't do this if you are in your office in the depths of the hospital and not aware of the current practices, the current barriers, and the current pain points. Get involved. Find out what's happening. Just a little statistic here, and many of you may know it. When nurses' workload exceed optimal levels, the chances of patient safety incident increase by up to roughly 30%, and the chances of patient mortality spiked by about 40%, and that was according to a study published in BMJ Open. When there is severe opposition, include the staff to come up with creative solutions that are within the protocol and will satisfy the needs of all involved. This is your opportunity to develop relationships and win hearts and minds, like we say here at BioVigil. Developing those partnerships and alleviating opposition. Some common reasons for resistance and opposition. Uncertainty and insecurity. As I stated earlier, nurses are afraid of change. Everyone is afraid of change. We don't like change. No one wants to make a mistake and lose their job. Other reasons, reactions against the way things are presented. I'm just being told what I need to do. I had no input. I had no say. I had no knowledge that there was truly a problem. Threats to their vested interests. Again, we're talking about jobs. No one wants to lose their job. No one wants to lose their credibility. And no one wants to have their character attacked. Cynicism and lack of trust. Be mindful that everybody is a professional. Everybody met the requirements to do the job that they are doing. And the perceptual differences and lack of understanding. We need to collaborate to ensure that everybody is on the same page. From here, we'll discuss mitigating some of these risks of patient safety. In mitigation, we take preventative measures to reduce the likelihood of the risk or to reduce the impact of the risk in case it occurs. After assessing your risk, in your project, you must address and control those risks. We know what those risks are. Right now, we're talking about increased hospital-acquired infections, lack of or ignore patient protocols, and impact to the financial bottom line. I am no expert on risk mitigation, and I have not had great exposure to it. I haven't had great exposure to risk management as a nurse, but I do have a knowledge base, and this is what we're going to discuss. So on risk mitigation, you're going to develop an impact analysis. A definition of that is identifying the potential consequences of a change or estimating what needs to be modified to accomplish a change. You're going to develop a committee that includes all disciplines, and specifically those who direct patient care responsibilities. They will help review and rewrite procedures, protocols that align with excellent patient outcomes and thus excellence in overall service and satisfaction. In many cases, as I stated before, decision makers are so far removed from the bedside, they don't realize what has changed since they've been there. Ensure that everyone is in the know about current procedures, staffing rules, regulations, and workflows prior to implementing change. You want to level the playing field. I talked about the hierarchy previously. We want to alleviate those errors when it comes to procedures and protocols. Everyone should have to follow the rules, and everyone should have to play by those same rules. As leaders, you must become system thinkers who demand in-depth analysis of safety concerns, who replace punitive reactions to noncompliance and mistakes with an open environment and proactively address any risk. There will be an opportunity to build safer healthcare organizations with these actions. However, we also have to know that there's no room for reckless behavior in the healthcare environment. And anytime we are ignoring patient safety protocols, we are ignoring rules, we are ignoring proven processes, that is reckless behavior. As we go through and work to mitigate our risk, it's important to share the findings with the staff so that they know what information is being collected. They know why the information is being collected. They understand how the data is being used, and they know how they are truly doing in regards to hand hygiene and patient safety. And then they can make the appropriate adjustments. Any data collected should not be used as a punitive factor, but as a tool for greater success. So again, you're going to measure your success. You're going to share out the information, and you're going to recognize your success. As I stated, I am not a specialist on risk mitigation, but a good resource for in-depth information can be found in the publication, Steps in the Process of Risk Management in Healthcare, and that's by Ali Alam. This webinar is not a sales pitch for BioVigil. Yes, I work here. I believe in the product, and I am a little biased because I know it works, and I have experienced successes with many of our clients. BioVigil provides several reports that can assist you with determining if you're on the path to where you want to go. The BioVigil data has proven to be beneficial not only as a hand hygiene reminder and awareness tool, it has been used to demonstrate the success in other patient safety areas, such as rounding and ensuring that the appropriate isolation precautions are in place as expected per protocol, and even identifying opportunities that will help to alleviate non-compliant behaviors. The next couple of slides are just examples of those reports. And the first slide is in the ICU, and yes, I am biased. It is a shortened version of the report. It shows when a user worked, their compliance, how many hand hygiene opportunities they had, and the larger report shows a lot more data. The next report is total compliance, and it's a monthly view of it. So it can show you your hospital's total hand hygiene opportunities for the month, your total non-compliance, and your overall compliance. These are just examples of what BioVigil can provide. In closing, hand hygiene is critically important to safe, high-quality patient care. Unfortunately, many infections are transmitted by healthcare personnel. To sustain improvement and make a difference, a simple slogan or campaign is not enough. Demanding that healthcare workers try harder is not the answer. Comprehensive, systematic, and sustainable change is the only solution. If you are interested in excellent hygiene compliance, give us a call. BioVigil can help you implement a sustainable change that will make a real difference. Let's partner together for greater patient safety.
Okay, thank you so much, Nifiah. Such interesting information from the perspective of a nurse, and I know that so many of us on the phone are focused on HAI reduction and increasing the top line and bottom line for hospitals. So we really appreciate that. And now I'd like to open it up to Q&A. And the first question, I actually received a question in email, and that is, Nifiah, if you could share your experience with nursing unions, hand hygiene, and compliance. I think perhaps what the questioner is talking about is, you elaborate a little bit on punitive issues, and I think there might be some correlation between punitive and nursing unions.
I believe, and I did work for a nursing union at my former employer. We were unionized. Our current clients are unionized. Some of them are. I think when implementing a process, you need to approach the union so that they can present the facts to the nurses. When you approach the union, you need to have all of the facts and show that there is understanding, so that understanding can be made, show that there is safety, and what the patient outcomes should be.
Okay, great. And then another question, what are some examples of positive reinforcement tactics that you've seen after implementation of such a system?
some of the clients actually do a rewards incentive program where they post their compliant users and they reward those users with gas cards, lunch, coffee. They make a big deal about it. Some of our, depending on how your organization is set up for communication, if there are visible TV boards or poster boards, they post those things so that everybody knows who the compliant users are.
Okay, great. And we have an online question. Can you design what it monitors? I think she's referring to BioVigil. For example, to start, could we program it just for in and out of patient room area?
Yes, the BioVigil system can be configured to initially just monitor in and out of the patient rooms if that's where you want it to start, but it does provide so much more coverage.
Okay. And could you please repeat the website you mentioned about recreating a risk assessment? And actually, we can include this on the link that we'll send out tomorrow as well.
Yes. So the name of the journal is the Journal of Epidemiology and Preventative Medicine. The article was Steps in the Process of Risk Management in Healthcare, and the author was Ali Alam.
Okay. And we have another online question. Can BioVigil measure quality of hand hygiene? And maybe you want to elaborate a little bit about what that means.
And I think what is being asked is if there is a protocol in place, can BioVigil manage that? And yes, we do. We designed the system based on your hospital protocols. And as I said, probably 10 times in this presentation, it's so important to have processes and protocols in place. So for instance, if your hospital's protocol is to wash your hands with soap and water for 20 seconds, we would design the system for your hospital wherein as that person would have to meet that requirement before they would get credit for that hand hygiene event.
Okay, thank you so much. And another question, how would a hand hygiene compliant system improve hospital culture? I know that's a topic we encounter quite frequently.
I think it lends to accountability. Our system, for instance, the way that it is designed, we use lights to demonstrate compliance. I think what our system allows you to do is to hold one another accountable. In my presentation, I shared a story about a patient who looked at a staff's badge, that the color on that badge was red, and they knew that meant stop, something needed to be done. Our system is designed like a traffic light, a simple traffic light. Red means stop, yellow is proceed with caution, green means you're good or go.
Okay. And I mean, how does that, I guess, improve the hospital culture among peers, among nurses, physicians?
Among peers, and what I see all the time, I see a lot of high-fiving in hospitals. Yeah, your hands are green. I see hospitals creating wreaths with BioVigil in green hands. I think it just lends to a very positive culture when everybody is doing the right thing.
Okay, and one thing, Nifiah, I think we should touch on is how would a hand hygiene system work in an emergency situation? You did mention emergencies, but I think if you could elaborate a little bit on how does that work?
So again, our system is totally configurable. So in an emergency situation, you have the option of performing hand hygiene if that is appropriate for that emergency. If it's not appropriate for that emergency, you can let the badge know by putting it in a state that you are in an emergency situation and you cannot perform your regular hygiene practice until that emergency is over. Once that emergency is over, you can remove it from that state and go back into your normal practice. So there are options that are conducive to an emergency situation.
Okay, great. I think that wraps it up for all of our questions for the time being. If those of you on the call have any additional questions, you can feel free to email me directly. Just respond to the webinar invitation or the links that we'll send you out tomorrow. But I would once again like to thank Nifiah for such an enriching webinar filled with content that we don't really get to hear very often. So thank you so much for joining us. And those of you who have joined us, I'd like to let you know that we do have another webinar lined up for next month. This will be with Lizette Alvarado from Quality and Risk Management Team from Lakeview Regional Medical Center, which is the campus of Tulane. And that will be June 28th at 2 o'clock Eastern Time, and more details will follow. So thank you again so much for joining us, and we wish you a pleasant day. Until next time, take care.